Have you ever found yourself wondering if that over-the-counter painkiller for your headache is truly safe to take alongside your daily prescription allergy medicine?
Hmm.
Or maybe you've heard the surprisingly common stories about grapefruit juice having odd effects on certain
Right,
medications.
those grapefruit stories always come up.
Exactly. These aren't just urban legends. They're real, everyday examples of how drugs, even those designed to save lives, never operate in a vacuum once they're inside your body. Okay, let's unpack this.
Indeed. The world of drug interactions is profoundly complex, um, a constant dance of biochemistry. But understanding this intricacy is critically important.
Absolutely.
Our mission in this deep dive is to equip you with a foundational understanding, moving far beyond just what happens when drugs interact, to really dissecting how and why these phenomena occur.
Getting into the mechanisms.
Exactly. The goal here is for you to develop a professional-level intuition, allowing you to anticipate these effects, much like an elite pharmacologist would.
And to help us truly master this information, we're drawing from an incredible source. A foundational text in pharmacology, specifically Chapter 67, titled Important Drug Interactions and Their Mechanisms.
A really solid resource.
It really is. This chapter provides truly comprehensive insights into how different substances can influence each other within the body. We've meticulously distilled the most important nuggets from this rich source, and trust us, there's a fascinating amount to uncover. So let's kick things off with the absolute basics. What exactly is a drug interaction? It sounds straightforward, but maybe it's not.
Well, our foundational text clarifies that it occurs when one drug alters the response to another drug, or even to a botanical medication, when they're administered concurrently.
Concurrently meaning like taken around the same time.
Yes, taken together or within a time frame where both are active in the body. What strikes me is how this immediately highlights that everything you put into your body, even a seemingly innocent supplement, can significantly impact how other medications perform.
That's a key point. So it's not just prescription drug versus prescription drug.
Precisely. These interactions are a significant and often overlooked factor in how a patient responds to medication. Understanding them is crucial for anticipating both beneficial and, more commonly, adverse outcomes.
Adverse outcomes being the main worry, I imagine.
Often, yes. The text categorizes these interactions into three main areas, providing a clear and logical framework for how we analyze them.
Okay, three main buckets. What's the first one?
Yep, so the first big category is pharmacokinetic, often abbreviated as PK.
PK. Got it.
This is all about what the body does to the drug. Imagine it as the drug's entire journey through your system, from entry to exit.
Okay, the drug's life cycle in the body.
You got it. Our source breaks this down into four critical sub-processes. First, there's absorption.
Absorption, how it gets in.
Exactly. How the drug actually gets from its administration site, say, your gut, if you swallow a pill into your bloodstream. Then comes distribution.
Distribution.
Yeah.
Yes.
Where the drug spreads throughout your body, traveling to its target sites. Third is metabolism.
Metabolism. The body breaking it down.
Right. Where your body chemically changes or breaks down the drug, often preparing it for elimination. And finally, excretion.
Getting rid of it.
Yes, how your body gets rid of the drug, primarily through urine or feces. Each of these steps, absorption, distribution, metabolism, excretion, or ADME as it's often called, is a potential point of interaction.
ADM. Okay, that's a useful acronym. So that's PK. What's the second category?
And then we shift our focus to pharmacodynamic, or PD interactions.
CD.
This category is about what the drug does to the body.
Ah, so the flip side of PK.
Exactly.
Yeah.
Here we're looking at how drugs interact at their actual site of action, whether it's a specific receptor, an enzyme, or a physiological process.
So the drug's direct effects.
Correct. These effects can manifest in several ways. They can be additive, where two drugs combine for a stronger effect.
Like 1 + 1 = 2.
Pretty much. Or synergistic, where their combined effect is greater than the sum of their individual effects, almost like a multiplier.
So 1 + 1 = 3, maybe?
Something like that, yeah.
Yeah.
A bigger bang for your buck, essentially. Or they can be antagonistic.
Working against each other.
Right, where one drug reduces the effect of another, essentially canceling it out or dampening it.
Okay, so PK is the journey, PD is the effect, additive, synergistic, antagonistic. Got it. Is there a third category?
Well, the third isn't so much a separate category as an acknowledgement that things aren't always neat.
The real world intrudes.
Doesn't it always? The source notes that some of the most significant interactions actually involve combined interactions, meaning two or more of these mechanisms, PK and PD, working together or overlapping.
Right, so an interaction could affect, say, how much drug gets absorbed and how strongly it binds to its target receptor.
Precisely. It's a complex interplay. Think of it like a cascade of effects rather than a single domino falling.
Okay. Now, you mentioned botanical medications earlier. Herbals. How do they fit in?
That's an increasingly relevant area. Our source unequivocally acknowledges that these do interact with each other and with conventional drugs.
So they can cause interactions, definitely.
Oh, absolutely.
Yeah.
But the information on these interactions is described in the text as scanty.
Scanty. Why is that?
This is primarily because they are much less well studied compared to traditional pharmaceuticals. They often lack the rigorous, large-scale clinical trials that conventional drugs undergo.
So less data, less certainty.
Exactly. The text even notes that some pharmacodynamic herbal interactions exist, as mentioned in its chapter 65, though we're not diving into that specific content today. But the potential is definitely there.
That's a crucial point because it really underscores the unknown variables we're dealing with when people mix conventional medications with less regulated supplements.
Huge potential for unexpected effects.
So when we talk about all these mechanisms, PK, PD, combined, what's the clinical so what? Why does understanding the how and why behind these interactions matter so profoundly for real-world patient care? Why dig this deep?
Well, if we connect this to the bigger picture, knowing the mechanism of an interaction is often clinically useful. Now, this isn't just academic trivia for a lab. It has immediate practical implications.
How so?
Understanding the mechanism influences both the time course and the methods of circumventing the interaction.
Okay, so knowing how it works tells you when it might happen and what you can do about it.
Exactly. For an elite professional, this means they can anticipate potential adverse events, gauge how quickly they might manifest, and then implement appropriate, targeted strategies to manage or even prevent them. It transforms reactive treatment into proactive patient safety, which is, a hallmark of truly mastering this field.
Proactive safety, I like that. Okay, so moving from the what and how to the when, let's talk about predicting the unpredictable, or maybe predicting the predictable. When drugs interact, how certain are we that an interaction will even happen?
That's a great question. Our source introduces a really helpful predictability scale, which is used in its comprehensive table 67-1. It employs 3 clear designations to estimate the likelihood of an interaction occurring.
Okay, a scale. What are the levels?
These designations are P, NP, and NE.
P, N, P, N, E. Right. What do they stand for?
P stands for predictable. This means the interaction is expected to occur in most patients receiving the combination. It's pretty reliable.
Okay, P for predictable. Makes sense. What about NP?
Then there's MP for not predictable. This means the interaction occurs in only some patients receiving the combination. It's more variable, perhaps influenced by individual patient factors.
So NP, it might happen, it might not. Depends on the person.
Largely, yes, or other factors we might not fully understand yet. Finally, NE is for not established.
Not established, so we just don't know.
Pretty much. It indicates insufficient data available on which to base the estimate of predictability. This doesn't mean it won't interact, just that we don't have enough clear evidence to predict its occurrence reliably.
Got it. P, NP, NE. Predictable, not established. But here's something important. Our source emphasizes this, right? These labels just say if the interaction will likely occur, not if it's actually harmful.
That is absolutely crucial to understand, yes. These designations simply indicate whether the interaction will occur. They do not necessarily mean that the interaction will produce an adverse effect.
So an interaction could happen, but the body just deals with it.
Exactly. An interaction might happen, but your body, with its robust compensatory mechanisms, might handle it without any noticeable negative consequences. It's about presence, not necessarily harm.
Okay, that's a key distinction. It raises an important question then, one that seems vital for that elite professional understanding. What genuinely determines if an interaction does produce an adverse effect that impacts the patient?
Right. This is where the individual patient comes heavily into play. Patient-specific factors are absolutely vital.
Like what kind of factors?
Well, their intrinsic drug clearance, essentially. How fast their body naturally processes and gets rid of drugs. That varies a lot between people.
Okay, how fast they clear things.
Then their unique genetics. Pharmacogenetics is huge here. How their genes influence drug processing enzymes or transporters.
Genes?
Wow.
Okay. What else?
Gender can play a role. Any concurrent diseases they might have, other health conditions, definitely influence things.
Like kidney or liver problems.
Exactly. Those are big ones for drug handling.
Sure.
And even something as seemingly benign as their diet can influence drug interactions. We mentioned grapefruit, but there are others. Each patient is really a unique pharmacological landscape.
It's fascinating how complex it is. So patient factors are huge. What about the drugs
Oh
themselves?
yes, it's not just the patient. The drugs themselves have their own characteristics that profoundly affect interaction outcomes.
Such as?
This includes drug-specific factors like the precise dose of the medication.
Yeah.
Higher doses often mean higher risk.
Makes
The route of administration, whether it's given orally, intravenously, topically, or something else, can change things significantly.
like IV might bypass some gut interactions.
Precisely. Then there's the drug formulation, which refers to how the drug is prepared and structured, immediate release versus extended release, for example.
Ah, okay. The pill itself matters.
It does. And even the sequence of drug administration, meaning the order in which they're taken, can sometimes matter. All these variables can subtly or dramatically shift the balance of an interaction, turning a theoretical risk into a clinical reality.
Wow. Dose, route, formulation, sequence. So many variables.
It's a lot to juggle.
Yeah.
So, given all these immense complexities and numerous variables, the drug's journey, its effects, patient idiosyncrasies, drug characteristics, what's the ultimate mitigation strategy to prevent harm from drug interactions?
Yeah.
What's the most important thing?
Yeah, how do doctors actually manage this?
Our source is very clear and concise on this. The most important factor in preventing harm is recognition by the prescriber of a potential interaction followed by appropriate action.
So it comes down to the doctor knowing and then doing something about it.
Exactly. It underscores the vital human element at the heart of pharmacology. It's not just about drugs and bodies. It's about the vigilance, the knowledge, and the informed decision-making of healthcare professionals who truly understand these intricate dynamics.
Vigilance and knowledge. Okay. All right, let's dive deeper then into that pharmacokinetic journey, that what the body does to the drug part, ADME. Let's start with the initial hurdles, absorption and distribution.
Sounds good.
Absorption first. That's the drug's grand entrance into the system, right? Getting from, say, the gut into the blood.
That's it. And as our source meticulously explains, this critical process can be significantly altered by other concurrently administered agents, even common ones.
Altered how? What are the ways this can happen?
Indeed. The source identifies 5 key mechanisms by which other agents can affect drug absorption in the gastrointestinal tract. First, we have adsorption.
Adsorption, like sticking to something.
Exactly. It occurs when drugs have a large surface area upon which the object drug can literally stick. Imagine a sponge soaking up liquid. In this case, the sponge drug adsorbs the liquid drug, preventing from being absorbed into the body. Certain antacids or things like activated charcoal work this way.
Okay, so one drug basically traps the other. What's next?
Then there's binding or chelation.
Binding or chelation sounds similar.
It's related but more specific. This is when drugs form strong chemical complexes with the object drug, essentially locking them together in a way that prevents either from being absorbed into the body. They become an unabsorbable unit. Think tetracycline antibiotics and calcium or iron supplements they chelate.
Ah, okay, forming a non-absorbable complex. Got it. What's number 3?
Third, and a very common mechanism, is altering gastric pH.
Changing stomach acid levels.
Right. Drugs like antacids, H2 antagonists, or proton pump inhibitors are designed to change the acidity of the stomach. This seemingly simple change can profoundly impact the dissolution of other drugs.
Why does pH matter so much for dissolution?
Well, many drugs require a specific acidic environment to properly break down and become soluble, making them available for absorption. If the pH isn't right, if it's too high, the drug might just pass through without dissolving properly and entering the system effectively.
Okay, so antacids can really mess with some drugs' ability to get absorbed.
Right.
What's the 4th mechanism?
Next up, we have altering gastrointestinal motility.
Motility, like how fast things move through the gut.
Exactly. This refers to changes in how fast food or drugs move through your digestive tract. If the GI tract speeds up, say with a laxative, there might not be enough time for the drug to dissolve and be absorbed properly.
Got enough contact time.
Right. Conversely, if it slows down, perhaps due to certain painkillers, it could lead to increased absorption for some drugs, or maybe even degradation of the drug before it gets its chance if it's unstable.
Okay, speed matters.
Yeah.
And the 5th mechanism?
And finally, a mechanism that involves the body's own gatekeepers, effects on transport proteins.
Transport proteins, like little doorways in cells.
Kind of, yeah. These are crucial cellular gateways, like P-glycoprotein and organic anion transporters, which actively move drugs across membranes, including those lining the gut wall.
So they pump drugs in or out.
Both, depending on the transporter and drug. If these transporters are inhibited, blocked, or less commonly induced, ramped up by another drug, it can dramatically change how much of a drug gets into the bloodstream from the gut.
Wow, okay. So adsorption, binding haltilation, pH changes, motility changes, and transport protein effects. 5 big ways absorption can be altered.
That's the breakdown from the source, yes.
Now, here's a critical distinction the source makes, one that you said is vital for thinking like an elite professional. The difference between a reduction in the rate versus the extent of absorption. Can you elaborate on that?
Yes, this is really key. A reduction in only the absorption rate is seldom clinically important.
Meaning, if it just takes a bit longer for the drug to get into your system, but the full amount eventually gets there, it's usually okay.
Generally, yes. For most drugs taken long-term, reaching the same total exposure, even if it takes a bit longer each dose, doesn't significantly change the overall therapeutic effect.
Okay. But what about the extent?
However, a reduction in the extent of absorption is clinically important if it results in subtherapeutic serum concentrations.
Subtherapeutic, meaning too low to work.
Exactly. This is crucial.
Mm.
It means not enough of the drug gets into your blood to actually do its job, rendering it ineffective for treating the condition. You're basically not getting the dose you think you are.
That sounds potentially very serious.
It can be. Conversely, an increase in the extent of absorption can also lead to adverse patient outcomes because too much drug can enter the bloodstream, potentially reaching toxic concentrations.
So too little is bad, too much is bad. It's a delicate balance.
Absolutely. The extent of absorption is critical.
Okay, that clarifies absorption. Once a drug is absorbed, it needs to get to where it needs to go in the body to exert its effect. That's distribution, right?
Correct. That's the next step in the PK journey.
And drug distribution interactions occur when one drug affects how another drug spreads throughout the body. Our source details 3 primary mechanisms here.
That's right. 3 main ways distribution can be affected by other drugs. The first is competition for plasma protein binding.
Plasma protein binding. Drugs hitching a ride on proteins in the blood.
Essentially, yes. Many drugs, once in the bloodstream, bind reversibly to proteins like albumin. Think of these proteins as taxis. If 2 drugs compete for the same binding site on these proteins, the same taxi stand, if you will, one can displace the other.
Ticket out of the taxi.
Yes. This increases the free concentration of the displaced drug in the plasma. And it's this unbound free drug that is generally the active form, able to leave the bloodstream, reach its target tissues, and exert its effect.
So more free drug means more effect, right? That sounds like it could be a big deal.
Intuitively, yes. And this is where it gets really interesting and challenges a common misconception that even professionals sometimes hold.
Oh, what's the misconception?
Well, it might seem logical that more free drug automatically means a significantly enhanced effect and thus more problems. Our source states that the clinical importance of protein binding displacement has been overemphasized.
Overemphasized, really. So it's not usually a major issue.
Current evidence suggests that such interactions are unlikely to result in adverse effects. This is because the body often compensates remarkably quickly.
How does it compensate?
Well, for instance, the liver and kidneys might rapidly increase the metabolism and elimination of the displaced, now free drug. So even though more is freed up initially, it gets cleared out faster, and the overall exposure might not change much or the increase is very transient. The body restores balance.
Okay. So the body's homeostatic mechanisms kick in? That's a fascinating nuance, a key takeaway for that elite thinking, maybe.
Yes, definitely. Recognizing the body's ability to adapt is crucial. So protein binding displacement, while real, might not be the clinical catastrophe it was once thought to be in most cases.
Good to know. What's the second distribution mechanism?
The second mechanism is displacement from tissue binding sites.
Similar idea, but in the tissues, not the blood.
Exactly. Similar to plasma proteins, drugs can also bind to proteins or other components in various tissues throughout the body. If one drug displaces another from these tissue sites, it would also tend to transiently increase the blood concentration of the displaced drug as it moves back into circulation. Again, often transient.
Okay. And the third mechanism?
And the third mechanism for distribution interactions involves alterations in local tissue barriers.
Tissue barriers, like the blood-brain barrier.
It's the prime example given by the source. P-glycoprotein inhibition in the blood-brain barrier. P-glycoprotein, which we mentioned in absorption 2, acts as a protective pump in the brain's blood vessels, actively pushing many drugs out of the brain.
Keeping unwanted stuff out?
Right. If you inhibit P-glycoprotein at this crucial barrier with another drug, more of a drug that's usually kept out can enter the brain. This could potentially lead to increased central nervous system effects, either desired, if that's the target, or adverse, that wouldn't typically occur.
So messing with these barriers can let drugs into places they shouldn't normally reach in high concentrations.
Precisely. It changes the drug's distribution pattern significantly in specific compartments.
Okay, we've thoroughly covered absorption and distribution, the initial phases of the pharmacokinetic journey. So let's move on to the next two crucial stops in ADME, metabolism and excretion.
Right, the M and E.
Let's start with metabolism. You described it as the body's chemical factory.
Yes, it's an incredibly complex factory, constantly processing and transforming substances. Our source explains that drug metabolism, primarily happening in the liver and the wall of the small intestine, but also in places like plasma, the lung, and the kidney, can be dramatically induced or inhibited by other drugs.
Induced or inhibited, meaning sped up or slowed down.
Exactly. And the importance of these effects, the text notes, can range from negligible to dramatic, fundamentally altering how a drug behaves in the body. This is a really critical area for interactions.
Why is it so critical?
Because metabolism directly impacts how long a drug stays in your system and at what concentration. If you speed it up too much, the drug might not work. If you slow it down too much, it might build up to toxic levels.
Okay, high stakes. Let's talk about enzyme induction first. Speeding things up.
Right. This is a fascinating process where one drug causes your body to produce more drug-metabolizing enzymes. The most famous and clinically important of these are the cytochrome P450 CYP isozymes.
Ah, the CYP enzymes. You hear about those a lot.
You do. They're a family of enzymes responsible for metabolizing a vast array of drugs and other substances. When these enzymes are induced by another drug, they go into overdrive, speeding up the breakdown of other drugs that they normally process, often dramatically.
So if drug A induces the enzyme that breaks down drug B gets cleared out faster.
Exactly. This can potentially make drug B much less effective or even completely ineffective because it doesn't stick around long enough or reach high enough concentrations to do its job.
Can you give some examples of these inducer drugs?
Sure. Our source gives us some key examples of known inducers. Powerful drugs like barbiturates, like phenobarbital, and carbamazepine, which are often used for seizures.
Okay, seizure meds.
Certain HIV medications like efavirenz and nevirapine, antibiotics like rifampin and rifabutin.
Rifampin is a big one, isn't it?
It's a classic, very potent inducer. And interestingly, even something seemingly natural like St. John's wort, a common herbal supplement which can significantly induce these enzymes.
St. John's wort, wow. Another reason to tell your doctor about supplements.
Absolutely critical. It's also vital to understand the time course for enzyme induction. It does not take place quickly.
It takes time. Why?
Because the body needs time to synthesize more of these enzyme proteins. It's not just flicking a switch. Maximal effects typically occur after 7-14 days of consistently taking the inducer.
A week or two for the full effect.
Right. And importantly, it requires an equal or longer time to dissipate after you stop taking the inducer. The enzymes hang around for a while.
So the effect lingers even after you stop the inducing drug.
Yes, for days or even weeks. The source also points out that induction isn't limited to the P450 enzymes. It can also increase phase 2 metabolism, like glucuronidation, which is another crucial pathway the body uses to modify drugs and make them easier to eliminate.
Okay, so induction speeds things up, takes time to start and stop, and involves making more enzymes. Now, what about the flip side? Enzyme inhibition, slowing things down.
Right. This is when one drug blocks or significantly slows down the activity of drug-metabolizing enzymes. When these enzymes are inhibited, the breakdown of other drugs that rely on that enzyme slows down.
Leading to
higher, potentially toxic concentrations of those other drugs building up in the body because they're not being cleared as quickly as usual.
That sounds like it happened faster than induction.
Generally, yes. The time course here is usually much faster, which is critical for clinical management. Inhibition takes place more quickly than enzyme induction, often beginning as soon as a sufficient concentration of the inhibiting drug is reached in the metabolizing tissue, like the liver.
So effects can be seen within hours or days.
Often, yes. However, there's a caveat. If the affected drug, the one whose metabolism is inhibited, has a long half-life, meaning it stays in the body for a long time anyway.
It takes longer to see the buildup.
Right. It may still take a week or more, or about 3 to 4 half-lives of that affected drug, to reach a new, higher, steady-state concentration, where the full impact of the inhibition is realized. But the process of inhibition starts much quicker than induction.
Okay, faster onset generally. And the list of inhibitors, is it long?
Oh, the list of known inhibitors is indeed extensive. Our source gives us a comprehensive rundown that includes many common medications.
Like what?
For instance, amiodarone, a heart medication, several antivirals like atazanavir and ritonavir, which are key parts of HIV therapy, common antibiotics such as chloramphenicol, ciprofloxacin, and macrolides like clarithromycin and erythromycin.
So common antibiotics can be inhibitors.
Yes, even common acid-reducing agents like cimetidine, Tagamet, though newer ones like famotidine or ranitidine are much less likely to inhibit.
Interesting. What else?
Then there are azole antifungals like fluconazole and ketoconazole, certain antidepressants like fluoxetine, Prozac, and fluvoxamine, and, as we hinted at earlier, pharmacoumarins.
Pharmacoumarins. That's the grapefruit thing.
That's the grapefruit thing. The specific substances found in grapefruit juice that are potent enzyme inhibitors, particularly of CYP3A4 in the gut wall.
Wow. That list is huge. It really highlights how many common things can interact by inhibiting drug metabolism.
It really does. Amiodarone, androgens, antivirals, chloramphenicol, cimetidine, cipro, macrolides, cyclosporine, diltiazem, diphenhydramine, disulfiram, azoles, SSRIs, grapefruit, isoniazid, metronidazole, mexilitine, omeprazole, quinidine, sulfonamides, verapamil, voroconazole, zephyrlucas, xylitol. It goes on. Constant vigilance needed.
No kidding. Okay, so that's metabolism, induction, speeding up, inhibition, slowing down. What about the last step of ADME, excretion, getting drugs out?
Right, excretion. This is the final critical step in the pharmacokinetic journey, how drugs ultimately leave the body. While the liver processes drugs for elimination via metabolism, the kidneys are a major direct pathway for drug removal from the blood into the urine. And this process, too, can be significantly affected by other drugs.
How can kidney excretion be affected?
One important way is through urinary pH changes.
Urine pH, how does that matter?
Our source explains that drugs that alter the urinary pH can influence the renal excretion of weak acids or weak bases. This goes back to a fundamental concept from Chapter 1, the Henderson-Hasselbalch equation.
Oh boy, chemistry flashbacks.
Well, the principle is fairly simple. Changes in pH affect the ionization state of drugs, whether they carry an electrical charge or not.
Okay, so
Essentially, if a drug becomes more ionized, meaning it carries a charge in the urine, it's harder for the body to reabsorb it back from the kidney tubules into the bloodstream. It gets trapped in the urine and excreted faster.
or charge faster out.
Generally, yes. If it becomes less ionized, more neutral, the opposite happens. It can be more easily reabsorbed from the tubules back into the blood, so it stays in the body longer. So drugs that alkalinize or acidify the urine can change the excretion rate of other drugs.
Interesting. What's another way excretion is affected?
And then there's active tubular secretion.
Active secretion, so the kidneys are actively pumping drugs out.
Exactly. Some drugs aren't just passively filtered by the kidneys, they're actively transported or pumped from the blood into the renal tubules by specific transporter proteins for elimination.
Like those transporters in the gut.
Very similar concept, yes. Key transporters involved here include P-glycoprotein, again, as well as organic anion transporters, OATs, and organic cation transporters, OCTs.
Okay, so what happens if these transporters are affected?
When these crucial transporters are inhibited by another drug, it can lead to increased serum drug concentrations because the drug isn't being efficiently pumped out and removed from the body. It essentially gets backed up.
Leading to potential accumulation and toxicity. So if you're thinking like an elite professional, you'd want to know which drugs use these transporters, right?
Absolutely. You'd know that many crucial drugs are partially eliminated by P-glycoprotein, including some very common and narrow therapeutic index ones like digoxin, a heart medication.
Narrow therapeutic index, meaning the safe dose range is small.
Precisely. Small changes in concentration can have big effects. Others include cyclosporine and tacrolimus, the immunosuppressants used to prevent organ rejection, dabigatran, an anticoagulant, and colchicine, used for gout.
Okay, important drugs. And what inhibits P-glycoprotein in the kidney?
And the plasma concentration of these crucial drugs can be significantly increased by inhibitors of P-glycoprotein, such as amiodarone, the macrolide antibiotics, clarithromycin and erythromycin, ketoconazole, ritonavir, and quinidine.
So combining, say, digoxin with clarithromycin could be risky.
Potentially very risky, yes. It means that co-administering one of these inhibitors with a P-glycoprotein substrate can rapidly push drug levels into the toxic range if not carefully monitored and managed, often requiring dose adjustments.
Got it. Okay, that covers the PK journey ADME, absorption, distribution, metabolism, excretion. Now let's switch gears to pharmacodynamic mechanisms. what the drug does to the body.
Right, the PD side of things.
And then we can delve into that particularly serious issue of combined toxicity, which you aptly called double trouble.
Sounds like a plan. So pharmacodynamic interactions occur when drugs directly affect the body in similar or opposing ways. They might be working on the same receptor, or different ones, but their ultimate physiological effect on the body is influenced by the presence of another drug, leading to an altered response.
Altered response, like stronger or weaker.
Both are possible. A common outcome is additive or synergistic responses. This happens when drugs with similar pharmacologic effects are given together, leading to an enhanced response. Think of it like a team-up, where the effects of two drugs combine.
Okay, teaming up. How does the source describe this?
Our source says that drugs acting on the same receptor or process are usually additive, up to a point where the receptor is saturated or the maximal effect is achieved.
Can you give an example?
A classic example given is combining benzodiazepines, like Valium or Xanax, plus barbiturates, like phenobarbital, both central nervous system depressants. Taking them together can predictably lead to greatly increased, potentially dangerous CNS depression.
Okay, combining sedatives makes sedation worse. Makes sense.
What's fascinating here, though, is the nuance that separates a basic understanding from true mastery. The source contrasts this simple additive effect with drugs competing for the same binding site.
Competing for the same spot, how does that change things?
In such cases, you might actually see less than an additive effect, especially if one drug is much weaker than the other. The weaker drug might act as a partial agonist or competitive antagonist, meaning it essentially occupies the receptor without fully activating it, or maybe only activating it partly, thereby blocking some of the stronger drug's ability to bind and exert its full effect. So competition can sometimes reduce the combined effect. It's a subtle but important distinction for professionals managing drug responses.
Interesting. Okay, so additive isn't always just simple addition if there's competition. What about synergy? That's like the 1 + 1 3 effect.
Exactly. Synergy is even more potent than simply additive effects. This happens when drugs act on different receptors or sequential processes, but their combined effect is greater than simply adding their individual effects together.
Can you give examples of synergy?
The source gives great examples. Combining nitrates, like nitroglycerin for angina, with sildenafil, Viagra, can lead to dangerously low blood pressure because they work on different parts of the pathway, controlling blood vessel dilation. But the combined effect is massive.
That's a well-known dangerous one.
It is. Another example is combining the antibiotic sulfonamides with trimethoprim. They inhibit two different steps in the same bacterial metabolic pathway, and together they synergistically enhance their antibacterial effects, making them a very effective combination. Bactrim receptor.
Okay, synergy can be good or bad depending on the context. What about the opposite, antagonistic effects?
Right. Conversely, drugs with opposing pharmacologic effects can reduce the response to one or both drugs. This is an antagonistic effect, where one drug essentially counteracts or diminishes the action of another. Think of a stimulant and a sedative canceling each other out, to use a simple example.
Okay, so how do clinicians manage these pharmacodynamic interactions, especially given they seem pretty common?
Well, the source reiterates that while these interactions are frequent, adverse effects can usually be minimized by understanding the pharmacology of the drugs involved.
So knowing how the drugs work is key.
Precisely. This allows for accurate anticipation of potential issues, like knowing not to combine nitrates and sildenafil, or being cautious with multiple sedatives and the implementation of appropriate countermeasures, like adjusting doses or choosing alternative drugs. It's about being prepared and proactive rather than reactive.
Prepared and proactive. Okay, and that leads us directly into combined toxicity or double trouble. This sounds serious.
It is. This is a particularly serious type of interaction. When two or more drugs, each with known toxic effects on the same organ, are used together. This combination can push that organ past its threshold for damage, even if each drug alone might have been tolerated.
Can you illustrate that?
The source provides a stark and critical example. Concurrent administration of two nephrotoxic drugs can produce kidney damage, even though the dose of either drug alone may be insufficient to produce toxicity.
Nephrotoxic meaning toxic to the kidneys.
Yes. So individually, each drug might be fine for the kidneys at its prescribed dose, maybe causing just a tiny bit of stress. But together, their combined burden hits a critical threshold for organ damage that neither alone would reach. This is a potent example of why a holistic view of a patient's entire medication list is so vital. You have to consider cumulative toxicity.
Wow. So it's not just 1 + 1 will 2 damage. It could be like 1 + 1 equals kidney failure.
In severe cases, yes, the risk is significantly amplified.
Is there more to combined toxicity?
Yes. Adding another crucial layer, which is often overlooked by less experienced professionals, is that some drugs can enhance the organ toxicity of another drug, even if the enhancing drug itself has no intrinsic toxic effect on that organ.
Wait, so drug A isn't toxic to the kidney itself, but it makes drug B more toxic to the kidney?
Exactly. It might interfere with the kidney's repair mechanisms or alter the metabolism of drug B within the kidney cells to create more toxic byproducts, for example. This means you can't just look at a drug's known side effects in isolation. You have to consider its potential to potentiate or exacerbate another drug's toxicity without causing direct harm itself.
That highlights a really deep level of insight required to truly master pharmacologic safety. You have to think about indirect effects, too.
Absolutely. It's about understanding the whole system.
Okay, we've broken down the how and why behind drug interactions, PK, PD, combined toxicity, predictability, patient factors. Now, how does this translate to real-world scenarios? To truly think like an elite professional, it helps to see these principles in action.
Right, applying the concepts.
From our foundational text, we've pulled out some examples from their comprehensive Table 67-1. Now, we can't cover the entire table. It's incredibly vast.
It really is. Pages and pages.
But we've selected key drug groups and interactions that powerfully illustrate everything we've discussed today. This will allow us to apply these principles to practical situations.
Good idea. Let's look at some specifics. Where should we start?
Let's start with a really common group, acid-reducing agents. Things like antacids, H2 blockers, PPIs. What are their properties that promote interactions?
Well, their properties are quite clear from what we discussed earlier. Antacids, for example, can physically absorb other drugs in the GI tract because they have a large surface area. They can literally bind to them and reduce their absorption.
Take that sponge analogy.
Exactly.
Yeah.
And other acid reducers, the H2 antagonists like famotidine or cimetidine, and the proton pump inhibitors like omeprazole or lansoprazole, their main job is to alter gastric pH, making the stomach less acidic.
And that impacts drugs needing acid to dissolve.
Precisely. It impacts drugs that specifically require an acidic environment to properly dissolve and be absorbed effectively.
Okay, so what are some key interactions listed for these acid reducers? What's the big takeaway?
Well, for many drugs that rely on an acidic stomach, taking an antacid or a PPI can predictably, designation P, render them much less effective.
Predictably less effective, like which ones?
For example, certain antivirals used for HIV, like atazanavir, fosamprenavir, indinavir, nelfinavir, and rilpivirine, see predictably decreased absorption because they need acid.
So a major issue for HIV treatment, potentially.
Absolutely. Similarly, many azole antifungals like itraconazole, ketoconazole, and posaconazole also have predictably reduced GI absorption due to the increased gastric pH.
Antifungals, too.
Even things like iron supplements show predictably decreased absorption when taken with calcium-containing antacids, and a whole class of kinase inhibitors used in cancer treatment.
Oh, cancer drugs.
Yes, many like dasatinib, erlotinib, gefitinib, pazopanib, and others predictably have reduced GI absorption because they need that acid. It's a fundamental principle. If the stomach isn't acidic enough, these drugs simply can't get into the system properly to do their job.
That's huge for cancer therapy. What about antibiotics?
Some antibiotics like quinolones, ciprofloxacin, etc., and tetracyclines also experience predictably decreased GI absorption, especially when taken with antacids containing multivalent cations like calcium, magnesium, or aluminum due to chelation or binding.
Okay, so acid reducers mainly mess with absorption via pH or bind and adsorption.
Got it. Let's move to another common substance.
Alcohol.
Yes, alcohol. Many people don't even think of it as a drug in the traditional sense, but pharmacologically it is, and it's surprisingly complex when it comes to interactions.
How so? What are its properties?
Well, its impact can range quite a bit. Chronic alcoholism can actually lead to enzyme induction. The liver enzymes get revved up over time.
So chronic drinkers might break down other drugs faster.
Potentially, yes. But on the flip side, acute intoxication like having a few drinks often inhibits drug metabolism transiently.
So one night of drinking slows down drug breakdown.
Correct. And severe alcoholic liver disease, of course, severely impairs metabolism overall. Plus, there's the potential for disulfiram-like reactions with certain drugs.
That's the reaction that makes you really sick if you drink.
Exactly, like the drug antabuse is designed to cause. And maybe the most common interaction, additive CNS depression.
Making you sleepier, less coordinated.
Yes, which is why alcohol plus sedatives, opioids, or antihistamines is so dangerous. That's a predictable P additive or synergistic CNS depression.
Okay, CNS depression is the big one. What else?
Well, with acetaminophen, Tylenol, for example, and chronic alcoholics, there's a not established NE, but potential risk of increased formation of hepatotoxic metabolites, meaning chronic alcohol use might make acetaminophen more damaging to the liver.
Important consideration for people who drink regularly.
Definitely. Another specific one is with acitretin, a drug for severe psoriasis. Alcohol, predictably. P increases its conversion to a highly teratogenic substance, atretinate, which persists for a very long time and is extremely dangerous during pregnancy. Strict alcohol avoidance is mandatory there.
Wow, that's a very specific and serious one. Okay, what about drugs causing that disulfiram-like reaction with alcohol?
Right. The classic is disulfiram itself, predictable, P. But others can cause it too, though often less predictably, NP or NE. Certain cephalosporin antibiotics like cefatent, metronidazole, an antibiotic, protozool, and maybe some sulfonylureas, older diabetes meds like chlorpropamide are noted.
So feeling really sick after drinking while on certain meds isn't just in your head.
Not at all. It's a real biochemical reaction for some combinations.
Okay, let's move on. Allopurinol, used for gout. What's its interaction profile?
Allopurinol's main property for interaction is that it inhibits certain hepatic drug metabolizing enzymes, particularly xanthine oxidase. A related drug, febuxostat, does this too.
So it slows down the breakdown of other drugs metabolized by that enzyme.
Exactly. And there's a crucial interaction here, which is predictable, P, and very significant clinically. It's with azathioprine and mercaptopurine.
Those are chemo drugs or used for immunosuppression?
Correct. They are metabolized and inactivated by xanthine oxidase. Allopurinol, predictably, puri, decreases their detoxification or metabolism,
Leading to
a dramatic increase in their concentrations and toxicity, particularly bone marrow suppression. This is a potentially life-threatening interaction if the dose of azathioprine or mercaptopurine isn't significantly reduced when allopurinol is started. It's a classic critical interaction to know.
absolutely critical. Okay, now oral anticoagulants like warfarin or the newer DOACs, you mentioned these are tricky.
They are a big one, yes. Given their critical role in preventing blood clots and their generally narrow therapeutic window, too much causes bleeding, too little allows clots.
What makes them so susceptible?
Their properties. Warfarin is metabolized mainly by CYP2C9, and it's highly protein-bound. The newer ones like apixaban and rivaroxaban use CYP3A4 and/or the P-glycoprotein transporter, so they are highly susceptible to induction or inhibition of these pathways. Small changes in their levels can have big consequences. Plus, other drugs can affect clotting factor synthesis or breakdown.
Okay, so lots of potential interaction points. What kind of drugs increase their effect, raising bleeding risk?
A huge number, honestly. Many strong enzyme inhibitors can predictably slow down anticoagulant elimination. Examples include amiodarone, a heart rhythm drug, certain antivirals, like ritonavir-boosted protease inhibitors, and most azole antifungals, ketoconazole, fluconazole, etc.
So common anti-infectives are risky.
They can be. Also, macrolide antibiotics like clarithromycin and erythromycin, not predictable on NP, but well documented. Metronidazole, P, trimethylsulfamethasozole, Bactrim P, and even cimetidine P can increase the effect, especially of warfarin. NSAIDs also predictably increase bleeding risk, partly by inhibiting platelets, but sometimes also via PK interactions or GI toxicity.
Wow, that's a lot of common drugs. What about things that decrease the anticoagulant effect, increasing clot risk?
Conversely, strong enzyme inducers can significantly decrease their effect, making the anticoagulant less effective.
Right.
Common antiepileptics like barbiturates, P-pen, carbamazepine P, phenytoin NP, and primidone P are major culprits.
Seizure meds again.
Yes. Also, the antibiotic rifampin P is a potent inducer that predictably lowers anticoagulant levels. Rifabutin P does too. And even the herbal supplement St. John's wort NP is a known inducer that can decrease anticoagulant effect.
St. John's wort keeps popping up.
It's a potent inducer affecting many drugs. This constant vigilance and often dose adjustment is crucial with anticoagulants, as their effectiveness can be so easily altered by so many things. Open communication with your healthcare provider about all medications and supplements is absolutely vital here.
Couldn't agree more. Okay, let's switch to antidepressants, tricyclic and heterocyclic, TCAs. An older class, but still used. What about them?
TCAs like amitriptyline or nortriptyline have several properties promoting interactions. They inhibit the reuptake of neurotransmitters like serotonin, 5-HT, and norepinephrine, NE. They often have significant antimuscarinic effects, dry mouth, constipation, etc. And crucially, they are susceptible to induction or inhibition of the enzymes that metabolize them, particularly CYP2D6, but also others like CYP3A4.
So interactions affecting their levels or adding to their side effects?
Both. For example, drugs that inhibit CYP2D6, like quinidine P, or the SSRIs fluoxetine and paroxetine P, can significantly increase TCA levels, raising the risk of toxicity like arrhythmias or seizures. Cimetidine P can also inhibit their metabolism.
Okay, inhibitors increase TCA levels. What about inducers?
Inducers like barbiturates P, carbamazepine P, or vampin P can decrease TCA levels, potentially leading to loss of antidepressant effect.
Right. And what about pharmacodynamic interactions, adding effects together?
Big ones there, too. Combining TCAs with MAO inhibitors is generally contraindicated due to the risk of hypertensive crisis or serotonin syndrome, NP. Combining with sympathomimetics, like decongestants, can lead to exaggerated cardiovascular effects. And their antimuscarinic effects can be additive with other drugs having similar properties, like diphenhydramine, Benadryl, P. They can also block the effects of certain blood pressure meds, like guanidrol P.
Lots to watch out for with TCAs. Now, anti-neoplastic agents, chemotherapy drugs, we touched on this, but let's focus.
Yes, cancer drugs. As we mentioned, many are substrates of CYP3A4, making them highly susceptible to enzyme induction and inhibition. And the stakes are incredibly high with these drugs.
Narrow therapeutic window, high toxicity potential.
Exactly. Small changes in concentration can mean the difference between effective treatment and severe toxicity, or even treatment failure.
So the interaction patterns are mainly about enzyme inhibitors and inducers affecting levels.
That's a major category, yes. Many drugs that inhibit CYP3A4, such as certain antivirals used for HIV, like ritonavir, P, or most azole and confofungals, ketoconazole, Atroxa, etc., PFE, can predictably decrease the metabolism of many anti-neoplastic agents.
Raising toxicity risk.
Significantly. Increased risk of severe side effects like myelosuppression, gastrointestinal toxicity, etc. On the other hand, potent enzyme inducers like barbiturates P, carbamazepine, kinetoin P, or rifampin P, and St. John's wort NP can predictably accelerate the metabolism of these cancer drugs.
Potentially reducing their effectiveness.
Right, possibly leading to treatment failure if the dose isn't adjusted or the inducer avoided. This really emphasizes why concurrent medication review by an oncology pharmacist or physician is absolutely non-negotiable in cancer care. Interactions can torpedo a treatment plan.
Critical point. Okay, let's move to azole antifungals themselves, like fluconazole, ketoconazole, itraconazole. They came up as inhibitors.
They did. Their primary interaction property is inhibition of CYP enzymes, especially CYP3A4. Though the strength varies, ketoconazole and itraconazole are generally stronger than fluconazole, and also CYP2C9. Fluconazole is significant here. Some also inhibit P-glycoprotein.
So they mainly cause interactions by slowing down other drugs' metabolism.
Yes, that's their major role in interactions. Because they inhibit CYP3A4 and P-glycoprotein, they can predictably increase the levels and potential toxicity of a huge number of drugs.
Like what kind of drugs?
We've mentioned several already. Many benzodiazepines like midazolam, alprazolam, certain calcium channel blockers like felodipine, nifedipine, cyclosporine and tacrolimus, many HMG-CoA reductase inhibitors, statins like simvastatin, lovastatin, or
Victims, yeah. Risk of muscle problems.
Exactly, increased risk of myopathy. Also, certain opioid analgesics like fentanyl, oxycodone, quinidine, sirolimus, many kinase inhibitors used in cancer. The list is expensive. They can also interact with oral anticoagulants like warfarin via CYP2C9 inhibition, P, and newer ones via CYP3A4P, G, GPP. And they can increase levels of colchicine, P, and digoxin, NP.
So azoles are interaction powerhouses due to enzyme inhibition. Do they get affected by other drugs too?
Yes. Because they are metabolized themselves, potent enzyme inducers like rifampin, P, carbamazepine, P, phenytoin, P, or barbiturates, P, can decrease the levels of the azole antifungals, potentially making them less effective at treating the fungal infection. And remember, their absorption can be affected by acid-reducing agents.
Right, the pH issue for some of them.
Okay.
Okay, next up. Barbiturates, phenobarbital, etc. We've heard them mentioned as inducers.
Yes, their main property is potent induction of hepatic microsomal drug metabolizing enzymes, especially CYPs like 3A4, 2C9, 2C19, and also P-glycoprotein. They essentially ramp up the body's drug-clearing machinery.
So they mainly decrease the levels of other drugs.
Correct. They can predictably decrease the levels and effectiveness of a wide range of medications by speeding up their metabolism or transport.
Examples.
We've hit many already. Oral anticoagulants, P, TCAs, P, many anti-neoplastics, P, azole antifungals, P, beta blockers, P, calcium channel blockers, P, corticosteroids, P, cyclosporine, P, doxycycline, P, estrogens, P, many statins, P, opioid analgesics, P, phenytoin, P, quinidine, P, theophylline, NP. The list goes on.
Wow, barbiturates really accelerate the breakdown of many things. What about additive effects?
Yes, the other key property is additive CNS depression. Combining barbiturates with other sedatives like alcohol, benzodiazepines, or opioids leads to significantly increased sedation and respiratory depression, which can be fatal.
Okay, powerful inducers and CNS depressants. Got it. How about beta-adrenoceptor blockers, beta blockers like metoprolol, propranolol?
Beta blockers have a couple of interaction properties. Pharmacodynamically, their beta blockade alters the body's response to sympathomimetics, like epinephrine. Pharmacokinetically, many undergo significant first-pass metabolism in the liver, especially propranolol and metoprolol, making them susceptible to drugs that alter liver blood flow or enzyme activity. CYP2D6 is key for many.
So, drugs affecting CYP2D6 can change beta blocker levels.
Yes, inhibitors of CYP2D6 can predictably increased levels of beta blockers like metoprolol and propranolol, potentially leading to excessive bradycardia, slow heart rate, or hypotension, low blood pressure.
What are some CYP2D6 inhibitors?
Examples include quinidine P, the SSRIs fluoxetine and paroxetine P, bupropion P, amiodarone P, cimetidone P, diphenhydramine MP, terbinafine P.
So combining Prozac with metoprolol could increase the metoprolol levels.
Potentially significantly, yes.
Yeah.
Dose adjustment might be needed. Conversely, drugs that induce metabolism might decrease their effect, though this seems less commonly cited than inhibition.
What about pharmacodynamic interactions?
While combining with calcium channel blockers like verapamil or diltiazem can have additive and negative effects on heart rate and contractility. They can blunt the effects of beta agonists used for asthma, like albuterol NP. They can mask or prolong hypoglycemia with insulin. And giving intravenous beta blockers after clonidine withdrawal can cause dangerous hypertension, NP. Also, NSAIDs like indomethacin might slightly reduce the blood pressure lowering effect, NP.
Okay, quite a few PD interactions too. Let's look at bile acid binding resins like cholestyramine or cholestyramine, used for cholesterol.
Right, their main property is simple. They bind with orally administered drugs in the GI tract, similar to absorption. They can form complexes that prevent the other drug from being absorbed.
So they mainly decrease absorption of other drugs taken at the same time.
Exactly. They can predictably decrease absorption of drugs like furosemide, a diuretic, mycophenol, an immunosuppressant, thiazide diuretics, and thyroid hormones.
So you shouldn't take these at the same time.
Generally, it's recommended to separate the administration times by several hours. Take the other drug either 1 to 2 hours before or 4 to 6 hours after the resin. They can also affect drugs undergoing enterohepatic circulation, like potentially methotrexate, NP, or leflunomide, NB, by binding them in the gut as they recirculate. They might also decrease digitalis absorption, NP.
Okay, separation of doses is key there. Next, calcium channel blockers, CCBs. We mentioned them affecting beta blockers, but what about their own interaction?
Right. CCBs like verapamil, diltiazem, and nicardipine are notable inhibitors of CYP3A4 and P-glycoprotein. Nifedipine and others are primarily substrates, not strong inhibitors. Their own metabolism is also susceptible to induction inhibition by other drugs acting on CYP3A4.
So they can cause interactions by inhibiting 3A4-PGP and be affected by 3A4 inducers inhibitors.
Exactly. As inhibitors, they can predictably increase the levels of other CYP3A4-PGP substrates. Examples include cyclosporine P, digoxin P, some statins like simvastatin, lovastatin P, tacrolimus P, sirolimus P, and potentially colchicine P, ergot alkaloids NP, certain opioids NP, and kinase inhibitors NPP.
Okay, so verapamil or diltiazem can raise levels of many drugs. What affects their levels?
Potent CYP3A4 inhibitors like enzol, antifungals P, macrolide antibiotics, clarithromycin or erythromycin P, and protease inhibitors like ritonavir P can predictably increase CCB levels, raising the risk of excessive vasodilation, low blood pressure, or bradycardia with verapamil diltiazem.
And inducers.
Potent CYP3/4 inducers like rifampin P, carbamazepine P, phenytoin P, baritrates P, and St. John's wort NP can predictably decrease CCB levels, potentially making them less effective.
Okay, busy interaction profile for TCBs. Let's tackle carbamazepine. Seizure med, also used for bipolar disorder and nerve pain. We've heard it's an inducer.
Yes, carbamazepine is a potent inducer of hepatic microsomal drug metabolizing enzymes like CYP3A4, 1A2, 2C9, 2C19, and P-glycoprotein. It's also metabolized primarily by CYP3A4, so it's susceptible to inhibitors and inducers of that enzyme, and it can even induce its own metabolism over time.
So it mainly decreases other drug levels, but its own level can be increased or decreased.
Correct. As an inducer, it predictably P decreases the levels and effectiveness of a huge range of drugs metabolized by the enzymes it induces. The list is very similar to barbiturates and rifampin. Oral anticoagulants P, TCAs P, antineoplastics P, azole antifungals P, calcium channel blockers P, corticosteroids P, cyclosporine P, estrogens P, many statins P, opioid analgesics P, theophylline NP, certain antivirals P, and many others.
Okay, a major inducer. What affects carbamazepine levels?
Strong CYP3A4 inhibitors can predictably P increase carbamazepine levels, raising the risk of toxicity, dizziness, ataxia, blood count changes. Examples include macrolide antibiotics, erythromycin, clarithromycin P, azole antifungals, ketoconazole, itraconazole P, protease inhibitors, ritonavir P, isoniazid P, cimetidine P, and verapamil-diltiazem P. Grapefruit juice can also increase its levels.
And what decreases its levels?
Other inducers can decrease its levels, potentially leading to breakthrough seizures. Phenytoin P, phenobarbital P, and rifampin P are key examples. And as mentioned, carbamazepine can induce its own breakdown over the first few weeks of therapy, autoinduction.
Complex drug. Okay, cimetidine, Tagamet, old H2 blocker for heartburn. You mentioned it's an inhibitor.
Yes, unlike the newer H2 blockers, ranitidine, famotidine, isatidine, cimetidine is a notable inhibitor of several hepatic microsomal drug metabolizing enzymes, including CYP1A2, CYP2C19, CYP2D6, and CYP3A4. It can also potentially inhibit the renal tubular secretion of some weak bases.
So it increases the levels of drugs metabolized by those CYPs.
Correct. It can predictably decrease levels and potential toxicity of drugs like theophylline, CYP1A2, warfarin, CYP2C90, phenytoin, CYP2C192C9, many benzodiazepines like diazepam, alprazolam via CYP3A4, TCAs, CYP2D6, 1A2, 3A4, certain beta blockers, metoprolol, propranolol via CYP2D6, lidocaine, CYP1A2, 3A4, quinidine, CYP343A6, and calcium channel blockers, nifedipine via CYP3A4. It can also increase levels of procainamide, NP, possibly via reduced renal secretion.
That's a lot of interactions for an over-the-counter drug.
It is, which is why the newer H2 blockers, or PPIs, are often preferred if interactions are a concern. Cimetidine's broad inhibition profile makes it prone to interactions.
Good to know. How about colchicine, used for gout?
Colchicine has a narrow therapeutic index and is susceptible to interactions involving its metabolism and transport. It's a substrate for both CYP3A4 and the efflux transporter P-glycoprotein.
So inhibitors of CYP3A4 or PGP can increase its levels.
Exactly. Co-administration with strong inhibitors of both pathways, or even just one, can predictably lead to increased colchicine concentrations and potentially life-threatening toxicity, muscle problems, bone marrow suppression, organ failure.
What are some key inhibitors to watch out for?
Strong CYP3A4P GP inhibitors like clarithromycin P, ketoconazole, letroconazole P, ritonavir P, and cyclosporine P are major concerns and often contraindicated or require significant dose reduction. Moderate inhibitors like verapamil-diltiazem P, erythromycin P, or even grapefruit juice can also increase levels.
And inducers?
Conversely, strong CYP3A4-PGP inducers like rifampin P, carbamazepine P, phenytoin P, and St. John's wort NP could potentially decrease colchicine levels, but the primary concern is usually with inhibitors causing toxicity.
Okay, toxicity risk is the main thing with colchicine inhibitors. Now, cyclosporine, the immunosuppressant, acrolamus and sirolimus are similar, right?
Yes. Cyclosporine, tacrolimus, and sirolimus, mTOR inhibitor, are all critical dose drugs used mainly for preventing organ transplant rejection. They are all major substrates for both CYP3A4 and P-glycoprotein.
So like colchicine, highly susceptible to inhibitors and inducers of those pathways.
Exactly, but perhaps even more critically, given their use and narrow therapeutic range, co-administration with strong inhibitors can dramatically increase their levels, leading to severe toxicity like nephrotoxicity, hypertension, neurotoxicity.
What are the major inhibitors increasing cyclosporine and tacrolimus levels?
Strong CYP3A4P GP inhibitors again, azole antifungals, ketoconazole, itraconazole, voriconazole P, macrolide antibiotics, clarithromycin, erythromycin P, HIV protease inhibitors, ritonavir, etc. P. Calcium channel blockers like diltiazem and verapamil P. Amiodarone P. Cobicistat P. Grapefruit juice is also a big issue.
And what decreases their levels?
Strong CYP3A4-PGP inducers can drastically reduce their levels, risking graft rejection. Key inducers are rifampin P, rifabutin MP, carbamazepine P, phenytoin P, phenobarbital P, St. John's wort MP, and some antivirals like efavirenz. Managing these interactions requires very careful therapeutic drug monitoring.
Absolutely critical for transplant patients. Okay, digitalis glycosides, mainly digoxin, heart medication.
Digoxin is another classic narrow therapeutic index drug. Its interactions involve several mechanisms. Its GI absorption can be altered, decreased by binding agents. Its renal and non-renal excretion is susceptible to inhibition, largely via P-glycoprotein, and its toxicity is significantly increased by electrolyte imbalances, especially hypokalemia, low potassium.
So P-glycoprotein inhibitors are a big concern for increasing digoxin levels.
Yes. Inhibitors of P-glycoprotein can predictably increase digoxin levels, sometimes doubling them, increasing the risk of toxicity, nausea, vomiting, vision changes, arrhythmias. Key PGP inhibitors affecting digoxin include amiodarone P, quinidine P, verapamil P, diltiazem P, cyclosporine P, macrolide antibiotics, clarithromycin, erythromycin P, some antivirals, ritonavir, etc. P, propafenone P.
Lots of common drugs there. What decreases digoxin levels?
Drugs that induce P-glycoprotein, like rifampin NP or the St. John's wort NP, can decrease digoxin levels. And drugs that bind it in the gut, like antacids NP, bile acid resins NP, or kalinpectin P, can reduce its absorption.
And the potassium issue.
Extremely important. Drugs that cause hypokalemia, like loop diuretics, furosemide, or thiazide diuretics, predictably increase the risk of digoxin toxicity, even if digoxin levels themselves haven't changed, because low potassium sensitizes the heart muscle to digoxin's effects.
Okay, watch potassium levels closely with digoxin. Next, disulfiram, antabuse, used to deter alcohol use.
Right. Its main mechanism is inhibiting aldehyde dehydrogenase, the enzyme that breaks down acetaldehyde, a toxic byproduct of alcohol metabolism. This causes the nasty reaction if someone drinks. It also seems to inhibit some CYP enzymes, notably CYP2C9.
So it interacts with alcohol predictably. Does it affect other drugs via CYP inhibition?
Yes, it can predictably increase levels of phenytoin and certain benzodiazepines, chlordiazepoxide, diazepam, by inhibiting their metabolism. It can also increase the effect of warfarin, P, likely via CYP2C9 inhibition, and combining it with metronidazole might increase psychotic reactions, NNE.
Okay, mainly alcohol interaction, but some CYP effects too. Estrogens, like in birth control pills or hormone replacement.
Estrogens are primarily metabolized by CYP3A4, making them susceptible to induction or inhibition of this enzyme. There's also a theory, though perhaps controversial or less significant than once thought for most antibiotics, that altering gut flora with antibiotics could interrupt the enterohepatic circulation of estrogens, potentially reducing their levels.
So the main concern is enzyme inducers lowering estrogen levels.
Yes, that's the most well-established interaction risk. Potent CYP3A4 inducers can predictably increase the metabolism of estrogens, potentially leading to decreased effectiveness like breakthrough bleeding or even contraceptive failure.
Which inducers are key here?
The usual suspects: rifampin P, rifabutin P, barbiturates P, carbamazepine P, phenytoin P, primidone P, St. John's wort P, and some antivirals like efavirenz, nevirapine P. Patients using these long-term often need alternative or additional contraceptive methods.
Critical counseling point there. Okay, HMG ketoA reductase inhibitors, statins, we keep mentioning them.
Yes, statins for cholesterol. As we noted, lovastatin, simvastatin, and atorvastatin are particularly susceptible to CYP3A4 inhibitors and inducers. Fluvastatin uses CYP2C9 more, pavastatin, rosuvastatin less so via CYPs. The major safety concern is additive risk of myopathy, muscle damage, or rhabdomyolysis when combined with other drugs that can cause muscle problems or drugs that significantly increase statin levels.
So strong CYP3A4 inhibitors are the big risk for increasing levels of simvastatin, lovastatin, atorvastatin.
Yes, absolutely. Combining them with strong inhibitors like azole antifungals, ketoconazole, etraconazole P, HIV protease inhibitors, ritonavir P, macrolide antibiotics, clarithromycin, erythromycin P, cyclosporine P, cobicistat P, nifazodone NP, or even large amounts of grapefruit juice can dramatically increase statin levels and the risk of severe muscle toxicity. Often these combinations are contraindicated or require using a different statin or much lower doses.
And what about drugs that also cause myopathy on their own?
Combining statins with other drugs known to cause myopathy, like gemfibrozil, a fibrate, NP, or sometimes niacin, also increases the risk, likely through additive effects or other pharmacokinetic interactions. Gemfibrozil inhibits statin metabolism too.
And inducers affecting statins.
Yes, potent CYP3A4 inducers like fampin P, carbamazepine P, phenytoin P, barbiturates P, and St. John's wort NP can predictably decrease levels of simvastatin, lovastatin, and atorvastatin, potentially reducing their cholesterol-lowering effectiveness.
Okay, statins definitely need careful interaction checks. How about iron supplements?
Iron's main interaction property is simple. It binds with drugs in the GI tract, forming non-absorbable complexes, chelation, thereby reducing the absorption of the other drug.
So similar to some antacids or bile acid resins, decreasing absorption.
Exactly. Iron supplements can predictably decrease the absorption of tetracycline antibiotics, quinolone antibiotics, and thyroid hormones. It can also decrease absorption of mycophenolate P and possibly methyl-dopa, NE.
So separate doses.
Yes, separating administration times by at least 2 hours is generally recommended to avoid these interactions.
Okay, simple binding interaction. Next, kinase inhibitors. These are mostly newer cancer drugs, right?
Yes, a large and growing class of targeted cancer therapies, ending in inhib, usually, like imatinib, dasatinib, or erlotinib, etc. Many of them are substrates of CYP3A4, making them highly susceptible to induction and inhibition. Some are also substrates or inhibitors of P-glycoprotein or other CYPs. Given their use in oncology and often narrow therapeutic windows, these interactions are critical.
So the pattern is similar to other CYP3A4 substrates like antineoplastics or cyclosporine. Inhibitors increase levels, inducers decrease levels.
Precisely. Strong CYP3A4 inhibitors like azole antifungals, PI protease inhibitors P, macrolides P, cobicistat P can significantly increase kinase inhibitor levels, leading to increased risk of their specific toxicities, which vary widely.
And inducers.
Strong CYP3A4 inducers like rifampin P, carbamazepine P, phenytoin P, barbiturates P, St. John's wort MP can dramatically decrease kinase inhibitor levels, potentially causing loss of efficacy and treatment failure. Managing these requires extreme care, often avoiding the combination or making significant dose adjustments based on specific guidance for each kinase inhibitor.
Okay, very important interactions in cancer care. Let's look at levodopa, used for Parkinson's disease.
Levodopa has some unique interaction properties. It's primarily degraded in the gut before absorption, and GI motility changes can alter this degradation. Its anti-Parkinsonism effect can also be inhibited pharmacodynamically by other drugs. Importantly, it's almost always given with carbidopa or benserazide, which prevent peripheral breakdown and mitigate some interactions.
Okay, so what interactions should we know about?
Well, metoclopramide, used for nausea-gastroparesis, can increase its absorption rate, but also has dopamine-blocking effects that can worsen Parkinsonism, NP. Dopamine antagonists, like older antipsychotics, phenothiazines, haloperidol P, or metoclopramide P, can directly block levodopa's beneficial effects in the brain.
So antipsychotics are a problem. What else?
High-protein meals can compete with levodopa for absorption and transport into the brain. Non-selective MAO inhibitors are contraindicated, P, due to risk of hypertensive crisis, though carbidopa helps prevent this peripherally. Pyridoxine, vitamin B6, used to increase levodopa breakdown, but this interaction is prevented by carbidopa. P, phenytoin might inhibit its effects, NE.
Interesting. Mostly PD antagonism or absorption issues. Lithium. Mood stabilizer. We touched on this.
Yes, lithium for bipolar disorder. Key properties. Its renal excretion is highly sensitive to sodium balance. Low sodium, high lithium retention. It's also susceptible to drugs that enhance its potential for CNS toxicity, confusion, tremor, etc.
So drugs affecting kidney function or sodium levels are the main PK interactions.
Exactly. Drugs that reduce renal clearance predictably, or non-predictably MP, increase lithium levels and toxicity risk. These include thiazide diuretics, P most likely, possibly loop diuretics, less likely, and NSAIDs, NP, except maybe Solandac and aspirin, ACE inhibitors, and NP, and ARBs.
Right.
Careful monitoring is essential when these are started or stopped.
Okay, diuretics, NSAIDs, ACE-ARBs raise lithium. What about PD interactions?
Combining lithium with drugs that can cause neurotoxicity might increase the risk, though often unpredictable, NP. Examples cited include haloperidol, potentially methyl-dopa, or even high doses of SSRIs in some cases. Theophylline, conversely, can increase lithium clearance B, potentially lowering its levels.
Got it. Renal interactions are key for lithium. Macrolides, erythromycin, chlorothromycin, azithromycin. antibiotics.
Right. We've seen them as inhibitors.
Yeah.
Clarithromycin and erythromycin are potent inhibitors of CYP3A4 and also inhibit P-glycoprotein. Azithromycin is generally considered much weaker, maybe a modest PGP inhibitor, but not a significant CYP3A4 inhibitor.
So clarithromycin and erythromycin are the main interaction culprits, causing increased levels of other drugs.
Yes. They can predictably increase levels and potential toxicity of many CYP3A4 PGP substrates. Examples include certain benzodiazepines, midazolam, triazolam, P, calcium channel blockers, felidipine, P, ergot alkaloids, P contraindicated due to vasospasm risk, statins, simvastatin, lovastatin, atorvastatin, P, cyclosporin nicotinimus, P, colchicine, P, digoxin, P, theophylline, P, grenadine, P, warfarin, NP, but significant, certain opioids, P, pimozide, P, QTC risk, and some kinase inhibitors, P.
Huge list again. Azithromycin is generally safer then.
Generally considered to have a much lower interaction potential, yes, which is why it's often preferred when interactions are a major concern.
Good to know the difference. Okay, monoamine oxidase inhibitors, MAOIs. Older antidepressants like phenelzine, tranylcypromine.
Yes, MAOIs. Their key properties. They non-selectively and irreversibly inhibit MAOA and MAOB enzymes, leading to increased stores of neurotransmitters like norepinephrine, serotonin, and dopamine. Displacement of these stored amines by other drugs can cause hypertensive crisis. They also have some intrinsic hypoglycemic activity.
So the big dangers are hypertensive crisis and serotonin syndrome.
Exactly. Combining MAOIs with indirect-acting sympathomimetics like pseudoephedrine, phenylephrine amphetamine P, or foods high in tyramine, aged cheese, cured meats, can predictably cause severe hypertensive crisis. This is the cheese reaction.
Okay, strict dietary and medication restrictions needed. What about serotonin syndrome?
Combining MAOIs with other serotonergic drugs is extremely dangerous due to the predictable P risk of potentially fatal serotonin syndrome, hyperthermia, muscle rigidity, confusion. This includes SSRIs, SNRIs, TCAs, triptans, certain opioids, especially meperidine, tramadol, NP, dextromethorphan, NP, St. John's wort. These combinations are generally absolutely contraindicated, requiring a washout period between drugs.
Absolutely critical contraindications. Any other MAOI interactions?
They can potentiate the hypoglycemic effects of antidiabetic agents, P. Combining with buspirone might cause hypertension, NP. Use with cocaine is dangerous, P.
Okay, MAOIs require extreme caution. Nonsteroidal anti-inflammatory drugs, NSAIs, ibuprofen, naproxen, etc.
NSAIs are everywhere. Their main mechanism is inhibiting prostaglandin synthesis via COX enzymes. This leads to several interaction properties: reduced renal sodium excretion, potential impairment of blood pressure control, reduced renal lithium excretion. Most also inhibit platelet function, increasing bleeding risk with anticoagulants.
So they mainly affect kidney function and blood pressure drugs, plus bleeding risk.
Yes, they can predictably blunt the effects of many antihypertensives, including ACE inhibitors, ARBs, beta blockers, NP, and diuretics, thiazides, loop diuretics, P. The combination can sometimes worsen kidney function too, especially with ACE-SARDs diuretics, the triple whammy.
So they can make blood pressure harder to control.
They can. As mentioned, they predictably increase lithium levels. They predictably increase bleeding risk when combined with anticoagulants like warfarin or DOACs, or antiplatelet agents like aspirin or clopidogrel. Combining with SSRIs might also increase bleeding risk, PP. Combining with methotrexate, especially high doses, can potentially increase methotrexate toxicity by reducing its renal clearance, NP. And combining with potassium-sparing diuretics like triamterene might increase hyperkalemia risk, NP.
Lots of common interactions with NSAIds. Opioid analgesics, morphine, oxycodone, fentanyl, etc.
Opioids. Key properties. Many are substrates for CYP3A4, like fentanyl, oxycodone, hydrocodone, methadone to some extent, or CYP2D6, codeine, hydrocodone, oxycodone, tramadol, rely on it for activation or metabolism. Methadone also uses CYP2B6 significantly, and of course they cause additive CNS and respiratory depression.
So, affected by CYP3A4 inhibitors like azole antifungals, P, protease inhibitors, P, macrolides, P, can increase levels of opioids like fentanyl or oxycodone, raising the risk of profound respiratory depression.
That sounds incredibly dangerous.
It is. Conversely, strong CYP3A4 inducers like rifampin, carbamazepine P, phenytoin P, can decrease levels of these opioids, potentially leading to withdrawal or loss of pain control.
What about CYP2D6?
Inhibitors of CYP2D6, like quinidine, fluoxetine, paroxetine, can block the conversion of codeine and tramadol to their more active metabolites, making them less effective. They might slightly increase levels of oxycodone or hydrocodone.
And the additive sedation, absolutely critical. Combining opioids with benzodiazepines, barbiturates, alcohol, gabapentinoids, or other CNS depressants significantly increases the risk of fatal respiratory depression. This is a major public health issue. And as mentioned, combining certain opioids like meperidine or tramadol with MAOIs is contraindicated. MP.
Okay, opioid interactions are complex and high risk. Phenytoin, another seizure med.
Yes, phenytoin, Dilantin. Key properties. It's a potent inducer of hepatic microsomal drug metabolism, CYPs like 3A4-2C family, and possibly PGP. It's also highly susceptible to inhibition of its own metabolism, primarily by CYP2C9 and CYP2C19. Its metabolism is also saturable, meaning small dose changes can cause large changes in blood levels, nonlinear kinetics.
So it acts as an inducer, decreasing other drug levels.
Correct. Like carbamazepine and barbiturates, it predictably decreases levels of many drugs, including corticosteroids, doxycycline, quinidine, theophylline P, calcium channel blockers P, cyclosporine P, estrogens P, many kinase inhibitors P, opioid analgesics P, and warfarin NP complex effect.
Okay, strong inducer. But its own levels are easily increased by inhibitors.
Yes, very easily, leading to toxicity, ataxia, nystagmus, confusion. Inhibitors of CYP2C9 or 2C19 can significantly increase phenytoin levels. Key examples include fluconazole, P, amiodarone, P, isoniazid, NP, chloramphenicol, P, cimetidine, NP, disulfiram, NP, sulfamethoxazole, as in Bactrim P, fluoxetine, NP, felbamate, P, and voriconazole P.
So many inhibitors can raise phenytoin levels. What lowers them?
Other inducers can enhance phenytoin metabolism, lowering levels and risking seizures. Carbamazepine P, rifampin P, phenobarbital P, and St. John's wort NP are examples. Chronic alcohol use might also lower levels. Managing phenytoin requires careful monitoring due to its complex kinetics and numerous interactions.
Very tricky drug, pimozide, an older antipsychotic, not used much but known for QTC prolongation risk.
Exactly. Its main interaction properties are being a substrate for CYP3A4 and its potential for additive QTC prolongation with other drugs that affect the heart's electrical cycle.
So avoid combining with CYP3A4 inhibitors or other QTC prolonging drugs.
Precisely. Strong CYP3A4 inhibitors like azyl antifungals, P, protease inhibitors, P, macrolides, clarithromycin, erythromycin, P, can dramatically increase pimozide levels, significantly raising the risk of life-threatening arrhythmias like torsades de pointe. These combinations are generally contraindicated.
And inducers.
Inducers like rifampin, P, carbamazepine, phenytoin, St. John's wort, NP, could decrease pimozide levels, but the main focus is avoiding the inhibitors due to the cardiac risk.
Okay, QTC risk is paramount with pimozide, potassium-sparing diuretics, spironolactone, aplerenone, amiloride, triamterene.
Right. Their main property is reducing potassium excretion. This means they have additive effects with other agents that increase serum potassium, leading to hyperkalemia by potassium, which can be dangerous for the heart. Eplerenone is also notably a CYP3A4 substrate. Amiloride and triamterene may alter renal excretion of other substances.
So the big risk is hyperkalemia when combined with other potassium-increasing drugs.
Yes. Combining them with ACE inhibitors, NP, ARBs, NP, other potassium-sparing diuretics, NP, potassium supplements, NP, or sometimes NSAIDs or cyclosporine etacrolimus increases the risk of hyperkalemia. Careful monitoring of potassium levels is needed.
And eplerenone, being a CYP3A4 substrate,
Means strong CYP3A4 inhibitors, azola antifungals P, protease inhibitors P, clarithromycin P, can significantly increase eplerenone levels and its risk of hyperkalemia. These combinations are often contraindicated or require dose limits. Conversely, CYP3A4 inducers, rifampin, P, carbamazepine, P, etc., can decrease eplerenone levels.
Procanacid's main property is interference with renal excretion of drugs that undergo active tubular secretion, particularly weak acids. It blocks the transporters, like OATs, responsible for pumping these drugs out into the urine. It might also inhibit glucuronide conjugation, a phase metabolism step.
So it increases levels of drugs eliminated that way. Yes. Classically, it predictably increases levels of penicillin and related antibiotics by blocking their renal secretion. This is sometimes used therapeutically to boost antibiotic concentrations. It can also increase levels and potential toxicity of methotrexate, P, clofibrate P, and possibly NSAIDs. It also interferes with the excretion of uric acid, which is its mechanism for treating gout, and salicylates can interfere with this effect.
Okay, blocks renal secretion of weak acids. Quinidine, old antiarrhythmic, also used for malaria sometimes.
Quinidine properties. It's a substrate for CYP3A4. It's a potent inhibitor of CYP2D6. Its renal excretion can be sensitive to urinary pH. Alkaline urine decreases excretion, and it causes additive QTC prolongation.
So, affected by 3A4 drugs, inhibits 2D6 drugs, and has QTC risk. Busy.
Very. As a CYP2D6 inhibitor, it can predictably increase levels of drugs metabolized by that enzyme, like many beta blockers, metoprolol, propranolol, TCAs, and it blocks the activation of codeine.
Okay, inhibits 2D6. What affects quinidine levels via CYP3A4?
CYP3A4 inhibitors like azoling antifungals, P protease inhibitors, P macrolides P, cimetidine P, amiodarone NP can increase quinidine levels, raising toxicity risk, including QTC prolongation.
And inducers decrease its levels.
Yes, CYP3A4 inducers like rifampin P, phenytoin P, barbiturates P, carbamazepine P predictably decrease quinidine levels, potentially making it ineffective.
And the QTC risk.
Avoid combining with other QTC prolonging drugs like pimozide, thiordazine NP, some antipsychotics, some antibiotics due to additive risk of torsades de pointe. Also, as mentioned, it famously increases digoxin levels via PGP inhibition.
Okay. Complex interactions for quinidine, quinolone antibiotics, ciprofloxacin, levofloxacin, etc.
Quinolones. Key properties. Their GI absorption can be significantly inhibited by binding junction with multivalent occasions like calcium, iron, magnesium, aluminum. And some quinolones, particularly ciprofloxacin and norfloxacin, are inhibitors of CYP1A2. Cipro is stronger and maybe weaker inhibitors of CYP3A4.
So absorption issues with antacids minerals and ciprofloxacin inhibiting CYP1A2.
Correct. Taking quinolones with antacids, sucralfate, iron, calcium, zinc, or dairy products can predictably decrease their absorption substantially, potentially leading to treatment failure. Doses need to be separated.
Okay, separate from minerals. What about ciprofloxacin inhibiting CYP1A2?
Ciprofloxacin can predictably increase the levels and effects of drugs primarily metabolized by CYP1A2. Key examples include theophylline, risk of toxicity, caffeine, jitters, clozapine, risk of toxicity, ropinirole, Parkinson's drug, tizanidine, muscle relaxant, contraindicated, and potentially warfarin, NP, bleeding risk.
So Cipro especially needs watching with those drugs. Levofloxacin or moxifloxacin are less problematic for CYP1A2 as
Generally considered much less likely to cause significant CYP1A2 inhibition, yes.
distinction. Rifampin, antibiotic mainly for tuberculosis. We know it's a major inducer.
Yes, rifampin is the classic potent inducer of hepatic microsomal drug metabolizing enzymes. CYPs 3A4, 2C9, 2C19, 1A2, 2B6, etc., and P-glycoprotein. Rifabutin is similar, but maybe slightly less potent.
So it decreases levels of almost everything.
It feels like it sometimes. It predictably decreases the levels and effectiveness of a vast number of drugs metabolized by these pathways. We've listed many already. Oral anticoagulants, TCAs, anti-neoplastics, azole antifungals, beta blockers, calcium channel blockers, corticosteroids, cyclosporineticoline, mucirolimus, digoxin NP, estrogens, progestins, contraceptive failure risk, statins, HIV protease inhibitors, and NNRTIs, kinase inhibitors, opioid analgesics, especially methadone, can cause withdrawal, phenytoin, quinidine, sulfonylureas, diabetes meds, P, theophylline P. The list is enormous.
So starting rifampin requires reviewing all other meds for potential dose adjustments or loss of efficacy.
Absolutely essential. It's one of the most powerful and broad-spectrum inducers known.
Okay. Salicylates, mainly aspirin.
Salicylates. Yeah. Properties. They can interfere with renal excretion of some drugs via active tubular secretion. Their own renal excretion depends on urinary pH, especially at large doses. Alkaline urine increases excretion. Aspirin, uniquely among common salicylates, irreversibly inhibits platelet function. Large doses can also have intrinsic hypoglycemic activity.
So interactions involving renal excretion, platelets, and maybe blood sugar.
Yes, aspirin predictably increases bleeding risk when combined with anticoagulants, warfarin, heparin, NP, or other antiplatelet drugs. Combining with NSAIDs also increases GI bleeding risk. Combining with SSRIs might increase bleeding risk. Salicylates can decrease the uricosuric effect, gout-treating effect, of probenecid and sulfapyrazone, P. They can displace methotrexate from protein binding and reduce its renal clearance, increasing toxicity risk. Combining with carbonic anhydrase inhibitors like acetazolamide can lead to salicylate toxicity, NP, and large doses might enhance the effect of sulfonylureas or insulin.
Okay, mostly bleeding risk and some PK/PD effects. Selective serotonin reuptake inhibitors, SSRIs, Prozac, Zoloft, etc. Common antidepressants.
SSRIs. Key properties. Pharmacodynamically, they increase serotonin levels, leading to risk of serotonin syndrome when combined with other serotonergic drugs. Pharmacokinetically, different SSRIs inhibit various CYP450 enzymes to different extents. Fluoxetine and paroxetine are potent inhibitors of CYP2D6. Fluvoxamine is a potent inhibitor of CYP1A2 and also inhibits CYP2C19 and CYP3A4. Others like sertraline and citalopram are generally weaker inhibitors overall.
So serotonin syndrome risk and CYP inhibition are the main interaction types.
Exactly. Combining SSRIs with MAOIs is absolutely contraindicated.
KP.
Due to high risk of fatal serotonin syndrome. Caution is also needed with other serotonergic agents like TCAs, also PK interaction, triptans, tramadol, St. John's wort, linezolid.
And the CYP inhibition.
Fluoxetine and paroxetine, as potent CYP-TD6 inhibitors, can predictably increase levels of TCAs, many beta blockers, metoprolol, etc., some antiarrhythmics, and block activation of codeine and tamoxifen. Fluvoxamine, as a potent CYP1A2 inhibitor, can predictably increase levels of theophylline, caffeine, clozapine, duloxetine, and warfarin. All SSRIs might increase bleeding risk with anticoagulants or NSAIDs,
So the specific SSRI matters for PK interactions.
Very much so. Fluvoxamine, fluoxetine, and paroxetine generally have the highest potential for PK interactions.
Okay, last one on this deep dive list, theophylline, used for asthma COPD.
Theophylline, classic narrow therapeutic index drug. Its main property is being highly susceptible to induction or inhibition of its hepatic metabolism, primarily by CYP1A2 and to a lesser extent CYP3A4. Small changes in clearance can lead to toxicity, nausea, vomiting, seizures, arrhythmias, or loss of efficacy.
So inhibitors of CYP1A2 increase theophylline levels.
Yes, significantly. Key inhibitors include ciprofloxacin P and other quinolones, fluvoxamine P, cimetidine P, macrolides, erythromycin, clarithromycin P, Zilodon, asthma drug, NP, diclopidine, antiplatelet, NP. These often require theophylline dose reduction.
And what decreases theophylline levels?
Inducers of CYP1A2 or 3A4. Smoking, tobacco smoke induces CYP1A2P, is a huge factor. Smokers often need higher theophylline doses. Other inducers include rifampin, P, carbamazepine, NP, phenobarbital, NP, phenytoin P, and St. John's wort. Starting or stopping smoking, or these inducers, requires careful theophylline level monitoring and dose adjustment.
Wow. Smoking status is critical for theophylline dosing.
Absolutely critical. It significantly impacts its metabolism. Theophylline can also interact pharmacodynamically, example causing additive toxicity with beta agonists, and it can decrease lithium levels.
Okay. That was an incredibly detailed tour through specific interactions, really bringing those principles to life. Thank you for walking us through that.
You're welcome. It's dense, but seeing the patterns across different drug classes really helps solidify the core concepts.
It really does. So what does this all mean? We've truly taken a deep dive into the vast and often complex world of drug interactions. We've explored in detail how pharmacokinetic mechanisms like absorption, distribution, metabolism, and excretion determine what your body does to a drug, and how other drugs can profoundly interfere with that journey.
The ADME pathways.
We've also looked at pharmacodynamic mechanisms focusing on what drugs do to your body, whether it's an additive effect, a synergy, or an antagonism. And we've learned how absolutely critical it is to understand the why behind these interactions, not just the what, to truly master this subject.
We've also seen that predictability varies P, NP, NE, and that the ultimate outcome of an interaction depends on a multitude of patient-specific factors, from genetics to diet and drug-specific factors like dose and formulation.
Right. And that the human element, particularly the prescriber's recognition of potential interactions and their appropriate informed action, remains the most vital safeguard against adverse events. It's about more than just a lift. It's about critical thinking. It's exactly. Vigilance and knowledge, as you said earlier.
So even if you're not a pharmacologist listening to this deep dive provides you with a robust framework for critical thinking about your own medications and overall health. It absolutely underscores the importance of open and thorough communication with your healthcare providers.
Couldn't emphasize that enough.
They need to know everything you're taking, from prescriptions to over-the-counter remedies, and especially those botanical supplements and even things like grapefruit juice, because as we've learned, everything can potentially interact.
Absolutely. Full disclosure is key to safety.
And as we consider this incredibly intricate dance of molecules within our bodies, think about this. How might advancements in personalized medicine, perhaps fueled by individual genetic profiling that predicts a person's unique enzyme activity or transporter function, how might that one day completely transform our approach to predicting and preventing these complex drug interactions? Could we move towards an era of truly tailored therapeutics where these unpredictable interactions become, well, predictable and avoidable for each individual?
Wow. Moving from population-based predictions, PNPNE, to truly personalized risk assessment, that's a fascinating thought to end on.